Good morning, everybody. Great to virtually be here with all of you again. And looking forward to the day, of course, when we can once again see you all in person. So I have the pleasure of introducing our keynote speaker this morning, Dr. Simon Mahler. He is an emergency physician, professor of emergency medicine and epidemiology at Wake Forest University in North Carolina. He's the director of clinical operations there, clinical research and operations there as well. And really has expertise in chest pain, in the use of accelerated diagnostic protocols, particularly the heart risk tool. And that's part of the reason we've invited him. The other thing I've sort of learned this morning this week as we were preparing is he's actually from Michigan. He grew up in Ann Arbor and got his medical degree from Michigan State. So it's awesome to welcome a native son home, even if it's virtual. So Dr. Mahler, the floor is yours.
Thank you, Keith. I really appreciate the introduction, and it's great to be with you today. As you mentioned, I was born and raised in Ann Arbor, Michigan, and so yeah, I wish I could be with you there in Michigan, but it's a great honor to speak to your group. So I do have a few disclosures. So chest pain is a serious problem, and as an emergency physician, I see patients with chest pain on every shift, usually multiple patients with chest pain. And this is a high stakes encounter. It's high stakes for the patient. If we miss the diagnosis of a myocardial infarction, that patient is going to have a really bad outcome. And it's high stakes for the provider as well. Number one cause of medical malpractice claims against emergency physicians is missed MI. So we see a lot of patients with chest pain in the US. Over 8 million patients present to emergency departments across the country complaining of chest pain. And we still, by and large, in most medical centers, when patients show up to the ED, they're either kept in an observation unit or admitted over half of the time. And we do lengthy evaluations on these patients. We do stress testing or other testing on them, and that costs a lot of money, costs up to $13 billion estimated each year. And so we use all these resources, we do all of these tests, we spend all of this money, and yet less than 10% of the patients that we're evaluating ultimately get diagnosed with an acute coronary syndrome. So we have massive over triage. But on the other hand, it's been estimated in some studies that we're still missing patients with ACS, and up to 2 to 4% of those with ACS may be missed and inappropriately discharged from the emergency department. So we have some under triage as well. So there's negative impacts to these inefficiencies, this over and under triage. So when we over triage, we crowd our emergency departments, we crowd our hospital wards, our observation units, and doing all this testing costs a lot of money. Most of these tests, or many of these tests, involve exposing the patient to radiation. And when we place patients at low pretest probability down a diagnostic pathway that includes tests like stress testing, that we're actually more likely to get a false positive stress test than a true positive stress test. And none of this is patient-centered. Dr. Grant was just talking about patient experience. Most patients don't want to be admitted unless they need to be. And so then on the under triage side, there's really important consequences to under triage, and missed ACS. That can have a devastating impact for the patient, and then of course malpractice, as I mentioned earlier. So one of the main reasons for these inefficiencies is care variability. We have providers that differ in their experience and their training. They differ in their risk tolerance. Their fear of malpractice can drive their decision making. And many of our providers are still using their Gestalt, or they're using old and unreliable tools for chest pain risk stratification. So there was a study done by Jesse Pines about 10 years ago where he actually used a validated scale, risk-taking scale, to measure risk aversion. And not surprisingly, in patients with chest pain, when there were more risk-averse providers, they had higher admission rates for those patients with chest pain. Many of our providers are still using clinical Gestalt, despite the fact that multiple studies have shown Gestalt is inaccurate. And most of the time, we as clinicians actually overestimate the risk of these patients, which leads to a lot of over-testing. On the other hand, sometimes we're underestimating risk, particularly when patients present atypically, and classically, and what we've seen is in women, we also tend to underestimate risk. So there's a number of different studies on this. So one of the studies that I like is by Rick Body, about 450 patients. What he did is he asked providers basically to what their Gestalt was and whether they thought it was definite ACS, probable ACS, definitely not ACS. And you can see the results here. When the providers thought this is probably ACS, 77% of the time they had no major adverse cardiac events. MACE stands for major adverse cardiac events, so death, MI, or coronary revascularization. When they thought it was definitely ACS, for sure this is ACS. ACS is my top thing on my differential. It was about a flip of the coin. 47% of the time, they had no adverse cardiac events. And then this is the scary one, when they said there's no way that this is ACS, not a chance, definitely not, still almost 10%, 9% now ultimately were diagnosed with MACE. So what's the bottom line here with chest pain? So this is a common condition, and our current patterns are inefficient, and care variability contributes quite a bit to this inefficiency. And Gestalt is not an accurate strategy to risk stratify these patients. So what are our tools in our toolbox when we decide we're going to address some of this care variability and some of these inefficiencies? And really the main tools of doing that are risk scores and accelerated diagnostic pathways or protocols. And I'm going to speak specifically about quite a bit about the heart pathway as it relates to ADPs. So first, a little bit about risk scores. These are tools that objectively combine clinical data to help us risk stratify patients as providers. And typically they incorporate some aspect of the patient history, their risk factors, their electrocardiogram, and then they often incorporate biomarker data. And when we're talking about chest pain, they're incorporating troponin as the main biomarker. So Timmy and Grace, these are kind of the old school tools, the original risk scores. These were actually never designed for emergency department use. These were designed for patients. They were derived and initially validated for patients with ACS, so patients that already were diagnosed with ACS, so those that were sitting in the CCU with MIs. This was used to determine their long-term risk. Subsequently, people looked at this and started using it in the ED, validated their use in the ED, but they were never really designed for that purpose. They do place patients into low, intermediate, and high risk groups, but the problem is with both of these tools that a low risk score is actually not good enough for you, not sensitive enough, not a good enough negative predictive value for you to exclude ACS and then feel comfortable discharging that patient. So while you can risk stratify them, you don't really have a low enough risk group that you can actually feel comfortable sending these patients home. So that leads us to the heart score. And the heart score was designed for the emergency department use, and specifically to help identify patients that are low enough risk that could be discharged. Which is developed in Europe and the Netherlands by Barbara Backus and Jacob Six. It's the HEART is an acronym, stands for history, EKG, age, risk factors, and troponins. Each one of those categories scored from 0 to 2, and then you add all of it up. And at the end, if you have a 0 to 3 total, that's a low risk score. 4 to 6 is considered moderate, and 7 or more is considered a high risk score. Sorry, I'm having a little bit of a lag with the, there we go. So the HEART score has been validated in well over 10,000 patients now. It's very commonly used, and it has about a 98% negative predictive value, maybe a little bit higher than that. One of the things you'll see on this graph is that as you go up with your HEART score, you see an increase in MACE precipitously here once you go to 4. There's sort of this inflection point at 4. So you can see the 0 to 3 is our low risk patients, 4 to 6 are our moderate risk, and then our higher risk here. So our group was the first to do a validation of the HEART score in the United States. We conducted a study with a little over 1,000 patients in our observation unit at Wake Forest, and this is a very low risk population. So back when I started working with chest pain at Wake Forest, we were admitting or placing in an observation unit over 80% of our patients that came in with chest pain. And so our ultimate MACE rate in these patients that went into the observation unit was 1.1%. So really low risk group. What we did was we applied the HEART score to those patients. And what we found was that we could have discharged 84% of that observation unit cohort with a negative predictive value for MACE of 99.4%. One of the things we did notice, though, is that we would have missed 5 patients with MIs that had low risk scores, all of which on a subsequent troponin would have ruled in for MI. And so that really gave us the idea that maybe HEART could be improved by using it as part of a pathway. I do want to share a little bit of how kind of HEART stacks up against TIMI as one of the older risk scores. This is data from the iTrax cohort, a large study, and you can see, if you're not really familiar with receiver operator curves, these are 2 different lines. This is HEART, this is TIMI. The better performance or more accurate a tool is, the more that the curve is going to be towards this corner. So having this HEART is clearly kind of well above the TIMI score, and you can see the area under the curve here is higher. So HEART was performed better than TIMI in this large study, and there's several others that provide similar results. There's been a couple recent meta-analyses from lots of studies that have been conducted with the HEART score, and the data from these studies, one had a pooled miss rate of about 1.6%. A larger one had a pooled miss MACE rate of about 2.1%. So that brings us to the question of, well, what's the acceptable miss rate? Is it okay to miss 2% of major adverse cardiac events? And I usually at this point poll the audience with a show of hands, but that's not possible for this type of interaction. But I can tell you that typically where people land is they either want it to be less than 1% or less than half of 1%. And this is actually consistent with what's been demonstrated in the literature and what most experts agree with. Less than 1% is really what's considered acceptable in the United States. And so the HEART score with a 1.6 to 2% miss MACE rate at 6 weeks, based on the meta-analyses, is not in that acceptable range. So how do we advance beyond risk scores? Well, accelerated diagnostic protocols are basically pathways, or accelerated diagnostic pathways they're pathways that incorporate a risk score with other clinical variables. So that might be their EKG, that might be biomarkers, or there may be other clinical variables that you add in with that risk score to get a better safety margin. And so when we were looking at that initial study of the heart score, we found that by adding a serial troponin by doing the 0 hour and the 3 hour, adding that to what we're calling a HERE score instead of the heart score, we actually could have had 100% sensitivity for ACS and still could have decreased our observation stays by 80%. So the heart pathway has improved sensitivity and negative predictive value compared to the heart score. So this is the heart pathway. This was the original heart pathway, which is based on contemporary troponins. I'll talk a little bit later about how this might be adapted for high sensitivity troponins. But this is an accelerated diagnostic pathway or protocol version of the heart score. And so it incorporates clinical variables. So the first step is actually looking at the EKG. If that EKG is non-ischemic, if they do not have known coronary disease, and they have a low HERE score, negative serial troponins, this is a patient that can be identified for early discharge. If they don't meet all of those criteria, they fall over here into a bucket of where they are being worked up additionally. So our initial validation was in the MIDAS cohort. This was 1,000 patients from 18 different US emergency departments. And this was a much higher risk cohort than the initial heart score validation that we did in the US. The ACS event rate was 22% in this cohort. But in this cohort, the heart pathway was over 99% sensitive for ACS and would have decreased admissions by over 20%. And we compared it head to head in this study with Gestalt, and heart pathway outperformed clinician Gestalt. So that study led us to the heart pathway randomized controlled trial. This was one of the LLSA, so like the recertification maintenance of board certification articles from 2018. We conducted this study just at Wake Forest. It was 282 patients randomized with equal probability to the heart pathway or care using the ACC/AHA guidelines. And we tracked these patients over 30 days, looking at a variety of health outcomes and safety outcomes. So what you can see is that we are actually able, with the heart pathway, to decrease admissions. We increased our discharge rate by 21% compared to usual care. So we sent home 21% more patients. We actually were able to decrease length of stay by 12 hours. So you can see that in this graph, we've got separation between the usual care and the heart pathway. This graph here is interesting because this shows what happens with the low risk patients, having a much lower length of stay compared to usual care, and then the high risk patients having a higher length of stay, which really speaks to the way that the heart pathway identifies the correct type of patient for admission. And in terms of stress testing, objective cardiac testing, we decreased that over a 30-day period by 12%. And all of this, as you might anticipate, by decreasing admissions and decreasing testing, resulted in a cost savings. And so we evaluated facility fees and professional fees, and we demonstrated a median difference of $216 per patient. And you can see how this broke out as we look at the different risk groups. So the low risk group, their cost of $746 and versus a much higher cost at high risk. And then here the usual care in the middle. So when we think about this cost savings of $216 per patient, and we can extrapolate that over the 8 to 10 million patients seen in the US each year, That's a considerable cost savings when extrapolated. That means if every place in the U.S. implemented the heart pathway, the potential savings is in the billions, 1.7 to $2 billion per year. So we were able to achieve all these efficiency gains without having any increase in adverse cardiac events. In fact, none of the patients identified as low risk by the heart pathway had any major adverse cardiac events. And the other thing you worry about when you do a study like this, or when you put in place something that's going to discharge patients more rapidly, whether or not those patients are just going to come right back, and whether you're going to have this revolving door where you're not actually decreasing the admissions, you're just kicking the can down the road, so to speak. And so we looked at this and we saw no significant increase in downstream hospitalizations, and we actually saw no increase in cardiac related repeat or return emergency department visits. So no increase in cardiac related recurrent care. So really, to summarize the initial heart pathway studies, is we've clearly demonstrated that we can reduce our healthcare utilization outcomes. We reduce stress testing, hospitalizations, length of stay, and cost, and we can accomplish this without increasing either adverse safety events or having increased recurrent cardiac related care. So the next step for us after demonstrating that was determining how do we use this best within the clinical workflow. And so we were able to get funding from the AAMC and the Donahue Foundation to do an implementation study where we implemented across the 3 hospitals within the Wake Forest Health System. And we actually integrated the heart pathway as a clinical decision support tool built into our Epic EMR, which went live in November of 2014. And so this was an intelligent contextual launch, which means that when a patient met certain criteria based on their age, their chief complaint, and whether or not a troponin was ordered, they received a best practice advisory or a pop-up alert that then sent them down a series of questions which they could answer and then get real-time decision support based on their answers. So a high-risk patient, they might get an at-risk message or a low-risk message depending on their score and their combination of troponin results. So the way that we designed this study was a pre-post interrupted time series. So we measured outcomes for 12 months prior to implementation. We had a brief wash-in period where we were implementing, and then we measured outcomes for 12 months after implementation. And so I'm going to show you some of the impact of that. First we had almost 4,000 patients, just under, in the pre-implementation phase, and we had well over almost 5,000 in our post-implementation phase, but very similar in terms of their makeup of male, female, and white, non-white. Total of almost 8,500 patients. And what we demonstrated was that we were able to achieve, after implementation, a 91% adherence in terms of use of our heart pathway tool, which is really high for the use of any type of pathway or protocol among physicians and advanced practice providers. And you can see here, we were able to reduce hospitalizations. The absolute reduction was 6%. You can see in the pre-period, we were actually having a slight uptrend over time in our hospitalization rate for patients with chest pain, and there was some variability from month to month. And here is our post-implementation period, and you can see that we actually had a downtrend over the year that we measured this, and also the clustering of these measurements. It's much more clustered, there's less variability. And so it shows the reduction in variability that you can get with using implementing a pathway. And importantly, what we were able to demonstrate is that among our low-risk patients, death in MI occurred only 0.4% of the time. And this was all-cause death. When we look further at cardiovascular death, the rate was even lower. If you use all-cause death, MI, and coronary revascularization for a MACE outcome, this only goes to 0.5%. So much lower miss rate than what we were talking about before with the heart score. We also demonstrated a significant reduction in length of stay as well. So I mentioned before that when I first started working with chest pain at Wake Forest, we were at 81% admission rate, and our length of stay was 22 hours. When we first started working with the heart pathway and started implementing that in our clinical workflow, we were able to reduce our admission rate to 61% and our total length of stay to 18 hours on average. And then integrating it fully into our electronic health record got us down a little bit more incrementally, down to about 56% and 16 hours on average length of stay. So the question is kind of, what do we do? Where do we go from here? Or still working on getting that lower. We're working on optimization of our integration within the EHR, and I'll show you some of that in a minute. And also with high sensitivity troponins, which if used properly can further drive down the number of patients that are admitted and reduce length of stay. So we did look at some subgroups here. We looked at women, and we did racial analysis as well. And what we found was actually that women were more likely, and actually non-white patients were more likely as well, to be identified as low risk compared to their counterparts. But importantly, there was no difference in safety events. It was safe. The heart pathway was safe in males, females, whites, and non-whites. So one of the things we were interested in also in this large cohort was to see whether or not there was a very low risk group of patients that could potentially be risk stratified without the use of a troponin. And so we looked at these patients with HERE scores of 0 to 1, and that was about 9% of our cohort. What we found was, even without troponin, we had a negative predictive value that was 99.1%. So a miss rate less than 1% in those patients. In fact, when the patients had a HERE score of 0, none of them went on to have an elevated troponin. And you can see here the negative predictive value for the 0-1. It's marginally, but not statistically significant, probably not clinically significant in terms of difference. Now, we have yet to this needs further validation. I'm not telling you not to send troponins on these patients, but in the future, we may be able to make that recommendation that patients with really low HERE scores may not even need a troponin. So what's the impact on observation unit? Many of you probably work at a hospital that has an observation unit, and what we found was that actually the heart pathway had very little effect on the number of patients that we put into our chest pain protocol. But what happened was, instead of putting low-risk patients in our chest pain protocol, we were putting patients that were intermediate risk in our chest pain observation unit. And so our patients were older, they were much more likely to have comorbid diseases, and they had we had a higher diagnostic yield for MI. And so you can see here our diagnostic yield prior, and then the diagnostic yield after implementation of the heart pathway. Now, 2% is still quite low, so we still have a lot of room to improve on this, but moving in the right direction. So how do we scale this? So one of the challenges is that what we did initially to build our heart pathway into the electronic health record was build directly within Epic. And even though we could share some of the code with another hospital, that hospital would basically have to write code, and every hospital that wanted to do that, to implement the heart pathway, would have to almost reinvent the wheel. I mean, we'd be able to provide a little bit of guidance, but it wasn't a scalable solution. And so that's when we started looking into SmartFire as a way of doing EMR integration. These are interoperability standards. They're web-based applications that can read and write to the EHR, and they're really agnostic to the EHR. So the same application can be used in Cerner as Epic. In some places where they have, some health systems actually have some sites on Cerner and some others on Epic, it can be used across that one system. It's less IT resource intensive because it requires very little build time. It really follows more of an app store model, and you are no longer constrained by the limitations of Epic or Cerner when you're developing your user interface. Your user interface can be more styled along, like you would a web-based interface. So I mentioned the App Store model. So the way this works is just like you download an app to your phone to improve the functionality of your phone. Now health systems have the opportunity to use either the Epic App Orchard or the Cerner App Store to download a healthcare app to their electronic health record to make their EHR work better, to improve the workflow for their providers and the care of their patients. So we have a heart pathway EMR app. It has better integration with the EMR, much faster and easier to use. And the other thing is that we're able to do is create a custom data analytics, basically an admin dashboard that's really useful for our administrators, for our medical director and operations team. This is what it looks like. You can see that this is obviously a fake patient. It's directly integrated into, this is in Epic. Same thing can happen in Cerner and actually in some other EHRs as well. But you can see it launches right into the Epic environment. So it's seamless. It's not like you're leaving to go to another website, and the provider basically clicks and makes some determinations, takes them through a heart pathway assessment, and ultimately, when they're done, they get to a results screen. So for those of you that have iPhones, we also developed a Heart Pathway mobile application. This is a free download from the iTunes App Store. So if you want to put the Heart Pathway application on your iPhone, it's free to do so. So the iPhone app helps with individual providers, whereas the App Store model helps it with an enterprise or health system based solution. So I want to talk a little bit about some of the current and future issues or questions about the heart pathway. And one of the biggest ones is, how do we use the heart pathway or modify the heart pathway once high sensitivity troponins come online? And we've done some studies with high sensitivity troponins. Actually, we did a study that was published back in 2017, well before we had approval of high sensitivity troponins and well before widespread implementation. And actually what you can see is compared to, this is a contemporary Siemens assay versus the Abbott high sensitivity troponin I, we didn't really have any major difference when we looked at 0 and 3 and we were using cut points at the 99th percentile. So we actually did not show in this is a smaller cohort. This was from our randomized controlled trial of 282 patients, but in that cohort, it really would not have changed our performance characteristics. But this basically means we could use the heart pathway the same way as we do with contemporary troponins and have very similar performance. The problem with that is we really would fail to take advantage of the new high sensitivity troponin assays' improved precision and their ability to detect MI much earlier. So we have some suggested major changes that we've made to the heart pathway at Wake Forest, and this is yet to be validated or published. But this is what we are doing at Wake Forest, and there are a couple other hospitals that are using this same protocol as well. So the first thing is including an option for a one and done strategy. So a one and done strategy means taking a very low initial. So on arrival, you get a high sensitivity troponin measure. If it's very low, usually right around the level of quantification, so right at the level where they can report it. With a low risk HERE score, those are patients that are potentially able to be discharged depending on the length of time that they've had chest pain. So usually if they've had chest pain for more than 3 hours and or their onset was more than 3 hours ago, I should say, if they have a low enough troponin, they might be able to be discharged with just a single troponin. The other thing is shortening that serial troponin measurement down. So we are a little bit more conservative. We went with a 0 and 2 as opposed to where we were before with contemporaries at 0 to 3. So we're able to shave an hour off of all of our chest pain workups. Some places are a little bit more aggressive and are using a 0 and 1 hour serial troponin. And you know, we can talk a little bit more if there are questions about why we made that decision. But there's literature that does support 0 and 1 hour as well. So the other thing was once you have a patient, even in that moderate risk with 2 negative high sensitivity troponins, you've essentially ruled out an MI for those patients. And so we are now discharging those patients with rapid follow-up rather than keeping them in our OBS unit or admitting them. So this is the new pathway incorporating high sensitivity troponin. You can see it's a lot more complex than the original heart pathway that I showed to you. It still starts with our EKG, so we're still incorporating clinical variables. We're still considering coronary disease and then a HERE score. Those patients with a low HERE score, if they have chest pain for onset of more than 3 hours and a very low initial troponin, they're eligible for discharge just on the basis of that one high sensitivity troponin. If not, if they have a 0 and 2 hours that is low with a low delta, those patients are identified for discharge. We have a much higher, so the 99th percentile is here at 19. We have a much higher kind of rule-in range. So we're using a rule-in range of 5 times the upper end of normal. And then we have an observation zone where we're doing more testing, more serial troponins for patients that fall in between. And you'll notice that we have this outpatient pathway. So if we have patients that have a HERE score of 4 to 6, but 2 troponins below the upper reference limit and without a significant rise, a delta rise, then those patients are eligible to go through an outpatient pathway where they get follow-up within 72 hours with cardiology who decides on further evaluation. So we talked about improving decision support a little bit, and with a more complex protocol, the need for decision support integrated into the EHR is that much greater. This is a little bit old. We have a newer version than this that actually also shows the delta, but you can see here, this is showing the risk score and then integrating the 2 different high sensitivity troponin results. Our newest one actually displays a delta value as well. And so then it integrates these and provides recommendations to the provider in real time. So the other thing that we've been examining is whether we can use the heart pathway in other healthcare settings. And in particular, we've been doing a lot of work on the pre-hospital environment. So can we use the pre-hospital to do better risk stratification prior to the patient arriving to the ED? And can we find patients in the EMS that maybe should be going to a different facility? So maybe patients who are having an MI shouldn't go to that local hospital where they're just going to need to be transferred. They should go directly to the tertiary care center where they have cath lab capability. Similarly, maybe a low risk patient might need an alternate, maybe they would benefit from an alternate destination. So that's what this type of protocol, a modified heart pathway for pre-hospital use, may be able to do. We just recently published this in PLOS One earlier this year. This is a study of 395 patients. The study was funded by Abbott. We basically equipped multiple ambulances across 3 different EMS agencies within North Carolina. We equipped them with iStat point of care troponin and iStat devices, and they would use the point of care troponin. So they would draw blood in the ambulance, they'd run the point of care troponin while they were in transport. And what we found was when these patients had a positive troponin, the specificity was really quite high. We had a total of our cohort had a pretty high MACE rate, so about 18.7%, and specificity for a positive troponin was 96.6%. So probably high enough for us to be making some decisions of maybe this patient with this elevated troponin should go to a tertiary care center. And the next part of the pathway is, if they are negative, is looking at the HERE score. And what we found was with the low risk HERE score and negative troponin, with the point of care, this got us to a negative predictive value of 94.4%. But we also ran that EMS blood on a more sensitive, now this was a contemporary assay, not a high sensitivity assay, but we were able to get that up to 100% negative predictive value when we ran this on a better troponin. So as what this tells us is that the iStat probably was not sensitive enough to exclude adverse cardiac events in the field, but as assays get improved, and there are new and improved point of care assays that are becoming available in the marketplace that will resemble even high sensitivity performance, that this may be possible. So I want to summarize by first thanking Medic for the opportunity to speak. Care variability and Gestalt are key drivers of inefficient chest pain care. And the heart pathway is a accelerated diagnostic protocol that safely can identify low-risk patients for early discharge from the emergency department. And in our opinion and experience, integrating this directly into the electronic record is going to enhance the usability and actually lead to greater efficiency gains, and improves the scalability of these ADPs as we look to do what Medic is doing to improve systems of care on a large scale. So I thank you for your attention, and I really appreciate the opportunity to have spoken with you today.
Thanks, Simon. That was awesome. And it's actually perfect because this is exactly where we are in our development as a collaborative, and trying to understand how we can exactly address the kinds of things you described here on care variability. I have so many questions, but personally, but I think we've got a few that are lined up from our audience. So I'm going to let Megan begin to call those out. So Megan, what questions should we start with?
Yes, so the first one was about whether you think that physicians will be resistant to using the SmartFire because it's just one more step in the documentation process.
That's a great question. Actually, the way that we have, the way that we've developed our tools, you know, I'm a practicing emergency physician, and all of the the team that I have working on this is our practicing emergency physicians, and so we were very cognizant of that. And the idea of double documentation is kind of a nightmare. So what we've done is when those, I showed you that integrated tool where you're clicking on some boxes. What happens there is we've developed a feature where that actually becomes a narrative that can be then basically pasted into your note. So you can drop that into your note, and so you don't actually have to double document. So when you're filling out the heart pathway assessment, you're actually filling out a level 5 history, and it just creates a narrative. And so that minimizes the documentation. It actually becomes almost, I'm not going to say it's a time saver, but usually it only takes about 30 seconds to go through the tool. And so at the end of 30 seconds, you push one button and you've got your history component written, and also your EKG interpretation.
Thank you.
Got some more?
Yes, we do. Yeah. The next question here is whether you have a key element of the heart score, such as the location or sharpness, that either really concerns you or reassures you, or is it really just the full picture?
Yeah, it's really the full picture. And there are, there's studies that show that certain aspects of the heart score are probably more important than others, but of course it's validated as a whole package. And so I wouldn't recommend, picking and choosing, because then it would no longer be validated. You'd have to validate that yourself prior to clinical use.
Can I follow up a little bit about that? One
Sure.
of the things I think that I'm mindful of is, there's a certain allure to the heart score because, it spells out heart.
Yeah.
It was developed in the ED, and there are several things that are pretty objective about it. But certainly, I think the one that's a little challenged around that is that history section, where it feels like it's a gestalt statement.
Yeah.
What's your sort of take on that, and any guidance around how to approach, in particular, assigning points to that particular domain?
Yeah, I'm really glad you asked that, actually. So one of the key, and I did not include it in my slide deck, but one of the key differences between the way that we use the heart pathway and the heart score is that we use objective criteria. We do not use Gestalt for our history, and so we require the provider to go through and go through key elements of the history and document those. And so it becomes much less subjective. We do, there are ways that you can operationalize this that aren't in the EMR workflow. Initially, when we did this, we had a little paper guidance to say, well, what really is moderate suspicion or high suspicion, or what's low suspicion as it relates to the H part, the history part of the heart score. So one of the reasons, actually, initially when we started working with the heart score, we had less guidance. We just used it like it was presented in Europe, and it was a full gestalt. And when our IRB, when we were doing our initial randomized controlled trial, one of the things our IRB required was that prior to any decision making being done, they wanted an expert to come behind and do a blinded assessment. So for every patient that got in a HEAR score or heart score done in our ED, we had an expert come behind them and do another one blinded. And initially what we found was that there were massive differences between our expert and our ED provider, and a lot of them had to do with this gestalt element in the history. And so we actually moved really towards making it completely objective.
I have seen at least some publications that suggest too that, provider to provider, at least the total tool is pretty reproducible. But, please correct me if I'm wrong about that.
Yeah, there are some different studies that show, so we've done some work with, and done studies that show, kappas that are acceptable. There are other studies that have not found that, so there's some variability there. There's a recent study, I believe, that came out of Vanderbilt maybe a year or two ago that showed that cardiologists and ED physicians couldn't agree on heart scores, and their agreement was poor. Yeah, but a lot of the most variability comes from that history section. There is some variability around EKG interpretation, and there's also some variability around risk scores, because we all know from working in the ED that a patient might tell us that they don't have high blood pressure, and you know, you go into their chart and they're on, you know, 3 different blood pressure medicines, and it's clearly documented. But you know, what I might put into the HERE score might be based on what the patient report is, and or the patient might with one provider forget to tell them that they have high blood pressure, and the next provider they say they have it. And so there are these when you do the provider you know, you do the inter-rater reliability, all those things factor in, and so it's not excellent. It's but in our studies it's been acceptable.
Yeah, I mean, I don't think that's specific to, you know, this particular risk tool. I mean, I think that's the reality of all risk tools, generally speaking. So,
and I think us having objective history component actually does help with the reproducibility as well.
Yeah. All right, I just monopolized a lot of time because I know there are other questions. So Megan, what else we got?
Yes, this one's a bit of a long one. So for patients with a low risk heart score that are being discharged, when are you recommending they get provocative testing and or expedited follow-up if you don't have rapid cardiology follow-up, as you alluded to?
Yeah, so what we did in our randomized controlled trial, which was really the first prospective study to discharge patients from the emergency department based on on the heart score or HERE score, we just recommended that they follow up with their primary care provider within 30 days for low risk patients because they're at very low risk. And based on the heart pathway, most recent large heart pathway data, the event rate is quite low for these patients over a 30-day period. And so, you know, we don't want to talk about it necessarily as a 30-day warranty, but if they can get follow-up within 30 days, we feel comfortable. We don't need to get stress testing. In fact, stress testing is probably counterproductive in the vast majority of these patients, even on an outpatient basis, because it's more likely to be a false positive than it is to be a true positive. And so really they need to follow up with their primary care provider. What we found is, and we didn't have as large of a reduction on stress testing over 30 days as what we thought we would. What we found is that still quite often the patient follows up with their primary care provider, and that primary care provider goes ahead and then orders a stress test anyway. But that's sort of to the next phase of working to improve that. You know, what kind of where we've been focusing, you know, first on our ED care of chest pain. But to answer your question, even though it's still somewhat at odds with guidelines, you know, 72-hour stress testing, really updated guidelines are no longer going to reflect the need to do that. And so we don't do that. We just have them follow up with their primary care doctor.
Yeah, I feel like there is this kind of undercurrent of a move away from, you know, the kind of sense of a mandate of requiring stress testing to further risk stratify this, you know, already low risk population. So do you see that in the future? You sort of mentioned probably the guidelines will catch up with that in a little bit, or?
Yeah, I'm fairly certain that the guidelines, which have been sort of in the ACC/AHA guidelines, were supposed to be revised and released a while ago. But I believe when they come out, this will be, first of all, they're going to be encouraging use of tools like the heart score, like the heart pathway. And secondly, the mandate for 72-hour follow-up with stress testing for all chest pain patients. I'm pretty confident that that will not be there anymore.
More questions, Megan? Yeah.
Yes. This listener is wondering, do you have data on MACE with HERE scores of 4 to 6 with 2 negative high sensitivity troponins who may be going home with rapid cardiology follow-up?
Yeah, so we actually just transitioned to high sensitivity troponin in August, and so we don't have a lot of data on this process yet. A lot of other places have rolled this out, and based on European data, we think this is going to be quite safe. But we don't have a lot of US data on those particular patients and on our pathway and exactly how it's working. And so I would say stay tuned, but we get the feeling that from the European data that this is going to be fine. A lot of the European data is just using troponins alone, like I'm not sure how familiar the audience is with the European Society of Cardiology recommendations and their ESC 0 1-hour algorithm, but these are troponin only algorithms that are being used, and they don't incorporate risk scores, and they don't incorporate other clinical variables like the EKG. So we feel like our pathway is going to be more robust by including some of those other clinical variables, but we also know that even with just using troponins alone, we can identify a relatively low risk or lower risk group.
More questions, Megan?
Yes, yeah, just one more here. This listener is wondering if you are using the heart pathway for patients presenting with agonal equivalents like nausea and dyspnea.
Yeah, we do. That's a really good question. We do use it for patients with anginal equivalents. I will give the caveat that when you do your history for those patients, particularly for us, when we're using an objective history, those patients are going to tend to score lower. They're going to have less history points because a lot of it is based on classic. Do they have chest pressure and do they have arm radiation and so on. So patients who come in with shortness of breath, if we have a concern for ACS, we will still use the heart pathway. But there are some caveats. All of our studies included those patients, though. So all of the data that I presented to you today includes not just patients with chest pain. I tend to say chest pain, but really what we're talking about is a patient who presents to the emergency department with symptoms concerning for acute coronary syndrome. And I apologize if that was confusing. I use chest pain as a shorthand, but really we're talking about the full spectrum of patients that could have ACS.
For the audience, you're welcome to continue to submit questions. We have some time here. I'm going to unload some of mine actually, because I have a lot that I want to pick your brain about. And one of the things I'm really mindful about here is, it sounds like you've got a lot of experience in sort of the real world implementation of these kind of pathways, particularly centered around heart score or the heart pathway. I'm mindful that we have 23 different types and flavors of EDs, lots of different types of settings, rural, urban, suburban, small community, academic centers with trainees. Any advice about how to roll something like this out, given some of those realities in the context?
Yeah, we actually did some qualitative work studying this, and we actually published a manuscript on some of the barriers and facilitators to implementation. And of course, just with anything, and I'm sure your group knows this really well, it all starts with getting all of this, having a champion and getting the stakeholders, key stakeholders involved. That is key. But usually the main barriers really are on the IT side. And a lot of community hospitals lack bandwidth in the IT areas, and even the academic centers can be, or large tertiary care centers can have IT departments that are overloaded with tasks, and so that can become a real barrier. And that was one of the reasons that we decided to develop this scalable app that requires really minimal development. It can be downloaded. And we've had hospitals that have downloaded it and been able to use it within a matter of hours. So the development time and the IT budget is super, condensed and small. So IT has been a huge barrier that we found initially when we tried to do some scaling of this. The other thing I would say is, whenever you try to implement, obviously, those of you that have worked in implementation, there's always early adopters and then there's late adopters, and having some system. The reason why we were able to achieve 91% adherence was because we had an audit and feedback system, and having some way of pinging your providers that are not doing it, and those that are rewarding those that are doing it, a carrot and stick type of mentality. And so we identified our providers that weren't doing it and provided them with re-education opportunities until they finally got the message to do it. And so those kind of things are key in terms of getting the group in line to do it. And of course, you need to have buy-in from, as I said, from all the key stakeholders and leaders within your institution.
I'm curious, like on the provider front, in your experience, what seems to be the main source of, let's say, main barrier to adopting this? I mean, is it sort of fear of missing the events? Is it around that? Is it just like the standard kind of behavior change? Like, I'm used to my stuff and I don't want to change. And
I think that the latter is the biggest aspect of it, is just the human behavior side of things. And as physicians, we tend to be pretty resistant to change. And the other thing that we're resistant to is the idea of cookbook medicine and the idea that we will use our brains and we'll know best. Unfortunately, the data doesn't support that we can use our gestalt and do a great job. It's interesting, there's a study, I think it was Jeff Klein, and I think it was on PE work, but a study where basically looking at Wells, maybe it wasn't Jeff, but it was a study on the Wells score for PE, and for a third of the providers, it really improved their ability that they had a poor gestalt. And so for a third of the providers, really dramatically improved their ability to pick up PEs. And for a third of providers, it was about their performance about the same. And for a third of providers, they actually outperformed the Wells score with their gestalt. What a tool like this does is actually brings up the lower providers to that middle of the pack. But the problem is that I've never known a physician who says, well, I'm a lower provider, or my gestalt is not good, right? So it's tough. It's like that classic question where people are asked if they're a good driver or if they're above average driver, and then 85% of the respondents say they're above average, right? Which obviously is impossible. We have a blind spot when it comes to this, and so most of us don't want to be told how to practice medicine, and this is by many is seen as kind of a slippery slope kind of thing. Well, now they're telling me when I should admit and discharge a patient and what the risk of that patient is. Now, you still have to use, I still always give caveats that clinical judgment still has to be used. The no risk score or pathway can account for every scenario. There may be social situations, or there may be other risk factors that aren't included in the heart pathway that need to be considered. So you still have to be a clinician. But yeah, that's the major barrier, is people say, oh, I don't really need this. I'm fine on my own. I can just do my own thing or do what I've always been doing.
Thanks. Yeah. Any questions, Megan? Additional questions that have been coming in from the audience?
Yes, I think one related to what you've been discussing, but maybe a little more specific. How do you give feedback and or reassure providers who continue to admit people with undetectable troponins for concern for, quote, unstable angina?
Yeah, I mean, that's a tough one. One of the things that what we saw initially when we did our studies was early on in our randomized controlled trial, we didn't mandate adherence to our heart pathway protocol. So our heart pathway. So patients that were low risk, if they wanted to keep that patient in the hospital or in the OBS unit and stress test them, they could. And we saw that a lot early in our study, and it was frustrating for me. But then at the end of the study, it's interesting, our usual care group, when those patients were lower risk in usual care, I couldn't get my providers to keep them and follow the ACC-AHA guidelines. So part of it is just getting familiar, I think. But how do you, I think it's really just education, because there's lots of literature that now demonstrates the safety of these tools. And so just repeated education. If you compare their performance, if they're an outlier, showing them how they compare to their peers is a powerful tool to influence their care and practice changes. And so it can be it can be anonymized where everybody else is not necessarily listed, but they see how they stack up compared to their peers, and that's a very useful way of giving feedback.
For those in the audience, we have those tools, as you know, available. So underscoring the importance of that audit and feedback loop, I agree, that's a key component in any quality improvement process. Additional questions, Megan? I do have one more, and I'm curious about the sort of future state. You mentioned, I think, a lot of this potential towards the end of your talk around integrating high-sensitivity troponins. And I'm curious about, in particular, the role of HERE score as part of that. I mean, do you feel like that risk stratification tool is likely to continue to be of value in the next several years, even as these other things like high-sensitivity troponin come online?
I do, but that is actually, I mean, that's a really good question, because it is an open question in the literature right now. I mean, you have troponin-only pathways that are being demonstrated to be fairly robust. Most of the studies that have looked at those mainly use a index MI as the outcome, as opposed to looking at 30-day MACE. So that's one area where we don't have as much literature. There's a study that was done in Sweden, where they actually looked at the ESC01 by itself. It performed actually poorly for 30-day MACE, but when they added other clinical variables to it, EKG interpretation and elements of the history, they were able to have a much better and acceptable miss rate. So there are some studies that suggest that risk scores may be a benefit, and there's others that show it makes only a marginal difference. And so the jury is, I think, still out on this. We have some unpublished data that suggests that this may be more important in the U.S. Population than maybe it's been shown to be in Europe or in other places, where basically the performance of the ESC01 across, we did a study of about 1,400 patients, 8 U.S. EDs, and we were unable to validate the troponin-only strategies that are popularly used in Europe without the addition of a heart score. So we actually used heart score and not heart pathway in this particular study, but using the heart score in addition to a high sensitivity troponin was superior and got us to that negative predictive value that we want. So that's something that we hope to have published in the next few months.
Great. Well, I think we're coming to the end of questions. It's been awesome to talk to you, Simon. Thank you so much. You've really, I think, given us a lot to work with as we push forward in our quality improvement work, particularly in 2021. We'll talk a lot about that after the break here. We'd love to maybe set up another moment in the future where you can actually come back to your home state, and you talked about going to a football game, and we can figure that out too.
That'd be great. Go blue.
That's go blue certainly for me. I know there's other green and white people out there, so fair enough.
Well, I have ties to both, so.
Yeah, perfect. Yeah. I am sort of seeing the time here. We're actually a little bit early, which is great. So what I'm going to suggest is we take a break a little bit longer. Let's come back at 10:50. That'll be like an 8-minute break here, and then we'll start up 10 minutes earlier than what we've got on the agenda. So at 10:50, we'll see you all again. Again, thanks so much, Simon, and all the best.
Thank you.
Yeah.